Good morning. My name is Kristen Bagno from Emory University, and I'm honored to be moderating this sure to be excellent session today, along with Dr. Vijay Rao, who is our esteemed gold medal winner. This session is on how to stay out of trouble, and we're going to begin this session with last year's excellent gold medal winner from University of Pennsylvania, Dr. Lori Lemierre, who will be speaking to us about blind spots in head and neck imaging.
Good morning, everybody. It's my pleasure to be able to speak to you today about blind spots in head and neck imaging. This is a subject near and dear to my heart. I want to thank the entire ASHNR and the program committee for including me in this wonderful program this year, and to congratulate everyone on a great meeting. So we're going to talk today about perceptual and interpretive errors. We're going to review the definition of each of these. We're going to spend a lot of time studying interpretive errors. They're very, very important in head and neck. We're going to assess causes for these errors, and we're going to identify strategies to reduce them. And we're going to do this illustratively by reviewing a series of path-proven miscases. So let's define a blind spot. A blind spot is an area in your range of vision that you usually cannot see properly, but you really should be able to see. So we all know when we're driving a car, most of the cars we can see through our side and rear view mirrors. But there is that portion when we get to the periphery of our retina, a blind spot where we cannot see neither through our rear view mirror nor our side mirror. And so we typically only see this area if we look over our shoulder. That's how we accommodate. Pilots in the Air Force have these same problems. But thank goodness for artificial intelligence. With adaptive mirrors that are placed on our side view mirror, we are now able to see these cars in the blind spot. And on our country roads and streets with adaptive mirrors, we are now able to see the train in the distance. Now, perceptual errors are an abnormality that is retrospectively identified that was not seen by the radiologist at the time of initial film interpretation. And this is what we refer to as blind spots. They're areas that we just don't see or areas that we miss. Let's look at some examples. This is a missed necrotic lymph node in the retropharynx, a missed necrotic lymph node at level 3, a missed Delphian lymph node in the setting of laryngeal cancer, a missed external jugular chain node in the setting of skin cancer, a missed primary mucoepidermoid of the parotid gland, and a large missed metastasis in the cerebellum with significant edema. This is a missed horseshoe lesion of the supraglottic larynx. You see it here on the epiglottis and aryepiglottic folds. A missed tumor of the posterior oropharynx. A missed piriform sinus tumor. And a missed lung metastasis. And finally, this was a missed lesion in the cavernous sinus, and 2 months later we can see this malignant nerve sheath tumor has tripled in size. So what are causes of perceptual errors? Right at the top of the list is reader fatigue, just a lot of volume and long days. Distractions and interruptions are very important. Phone calls, texts, emails, consults, and just the high volume is a distraction unto itself. Satisfaction of the search. We get so fixed on a finding or a diagnosis that we forget to search the rest of our film. Suboptimal image quality, not doing the imaging modality of choice, and insufficient or wrong clinical history are very important in driving perceptual errors. A cognitive or interpretive error is a finding that is usually detected, but its meaning or its significance is not recognized or understood by the interpreting radiologists. And this is what I like to refer to as blind knowledge. And blind knowledge is really just a lack of understanding of anatomy or the pathology of the disease we're taking care of. And when this happens, they are often accompanied by perceptual errors. And quite frankly, many of these interpretive errors are in your face. They are large, large errors where we just missed the boat. So let's look at some examples. So these are venous thrombosis that was initially interpreted as necrotic lymph nodes. This is anaphylaxis that was interpreted as bilateral parotiditis. This is a swallowed foreign body that was interpreted as a styloid ligament. This was interpreted as a vein. It is perineural spread. This is a clival lesion, misinterpreted as a metastasis. And this is tongue paralysis that was read as a base of tongue tumor and leading to the miss of the metastasis in the occipital condyle. Causes of cognitive or interpretive errors, lack of knowledge or subspecialization, and in ENT, we all know this is very, very important. Incorrect or insufficient clinical history, misguided clinical history, failing to use prior imaging or reports, propagating an error on prior imaging reports, and this is a big pet peeve of mine. People just keep propagating the wrong information. Fixation on a specific diagnosis or findings such that you do not do the satisfaction of the search, and poor communication, unclear reports, and poor communication between radiologists and referring clinicians and between radiologists and the patients. So when we talk about blind spots and blind knowledge, these are symptoms that make me nervous. These are symptoms that should raise your suspicion and should make you go back and check a film before you sign off as normal. Facial pain, dysphagia, ear pain, dysarthria, the sensation of a bug crawling on my face, and headache. Facial pain, look back at those skull-base foramina for perineural spread on V2. Dysphagia, people look at the oropharynx and the esophagus, but they forget to look at the innervation of the pharynx and the innervation of the tongue. Dysarthria, the same thing. You've got to look at the 12th nerve and the 9th nerve. When I hear bug crawling on my face, I know there's a high likelihood that there's perineural spread, and headache is a very common presentation, not just for early denervation, but for bony lesions at the skull base. And this is priceless real estate that you must check out. The aerodigestive tract, the skull base, including the foramina for perineural spread and patterns of denervation. You've got to look at both of them. If you see perineural spread, you got to look at the muscles. If you see denervation, you got to look at the nerves. And finally, the bones. So let's look at this first patient, a 52-year-old with throat pain and coughing after swallowing a chicken bone. It's no surprise that the initial diagnosis was an aspirated chicken wishbone. This is the structure that you're looking at here. But when we look here, again, we see this ossified structure. And when we look at the coronal view, we see this is just densely calcified normal thyroid cartilage. It's not a wishbone. And if we go on to get some additional imaging, as this patient got, you will see that it's very important to look for normal structures every time you're assessing for foreign bodies. Think about what the cartilage is. Think about the hyoid bone. Think about an ossified stylohyoid ligament. And when in doubt, check it out. Get a CT as this patient had, and here you'll see this bilaterally symmetric, densely ossified normal thyroid cartilage. The foreign body had long passed through the throat into the aerodigestive tract by the time of imaging. This is a 44-year-old with a sore throat after eating. The initial diagnosis of this plain film radiograph was normal. Then we got the additional history of eating sea bass. This finding was seen here, this linear high density, and the final interpretation on this was the styloid process. Patient went on to get a CT scan for persistent symptoms. Here you'll see linear high density tracking down the submucosal oropharynx. The tip is at the pharyngoepiglottic junction, and the final interpretation was a calcified stylohyoid ligament. But when we do some coronal reformatted images, you will see the styloid process here, and it would travel down this way. And here is the linear structure we were looking at, the fishbone, that again inserts at the pharyngoepiglottic junction, and this is a sea bass fishbone. So to review the styloid process and the stylohyoid ligament, remember the mastoid process, you have the styloid process emanating from it. From the styloid process to the lesser cornea of the hyoid bone, you have the stylohyoid ligament that runs between the internal internal and external carotid artery, and it may calcify. This is what it looks like on a sagittal radiograph. We see the styloid process, the ossified stylohyoid ligament, and if you look, it inserts on the anterior third of the hyoid bone where the lesser cornua is. In contrast to the patient that we're looking at, where we see the styloid process, the linear high density, and it's inserting along the epiglottis and projecting along the back third of the hyoid bone. This is the retained fish bone. Just in the COVID air, a high density structure projecting over the pharynx. On the AP view, we see the facial mask pulled down over the neck, so beware in the COVID air not to misinterpret this for a foreign body. This is a missed esophageal perforation in a patient that had a foreign body. We see the pneumatosis, the air in the esophageal wall, and air in the mediastinum between the hemiazygous vein and the esophagus. And this is a different missed perforation with retropharyngeal air. Here we see the constrictor muscles and the retropharyngeal air in front of the vertebral bodies. This is the esophagus anterior to the retropharynx. Here we see the air in the retropharynx ventral to the prevertebral muscles, and behind the constrictor muscles and in front of the spine and prevertebral muscles, retropharyngeal air. On a closer view at the thoracic inlet, you'll see the trachea and esophagus, the retropharyngeal air. Remember, the retropharynx can track all the way down to the core of the diaphragm, so you must check it. And here we have the missed lung nodule. So regarding oral foreign bodies in children, just remember, children have a natural tendency to put objects in their mouth. They can aspirate them, in which they're in the airway, and those patients typically present with choking or pneumonia. Occasionally in the delayed phase. The workup's a chest and soft tissue neck X-ray, followed by bronchoscopy and retrieval. If the foreign body is swallowed, it will get impacted in the esophagus frequently. Most of these impactions will be at the thoracic inlet, and if they are not detected early, they will result in a delayed presentation due to penetration and infection. So here's a drooling toddler. We see massive enlargement of the retropharynx in front of the vertebral body. We see air here, and 2 weeks earlier you can see the coin embedded in the thoracic esophagus. Again, that's where we go from skeletal to smooth muscle, which is why 70% of impactions occur there. And here we see the displacement of the trachea, so impacted foreign body in the esophagus. Now, this is a 25-year-old male with fever and respiratory distress. The initial diagnosis was pneumonia. And on the next CT, we see the patient is intubated with an oral enteric tube, so we know they're sick. And we see these necrotic masses that were read as necrotic lymph nodes. But if you go back and you take a good look, the pulmonary opacities, some of these are actually cavitary and wedge shape, and these are actually septic emboli. And when we go back and we re-review the CT, we see the jugular vein on the right, the carotid artery on the left, and this is actually clot in the internal jugular vein and the facial vein, and this is venous thrombosis. And had we gone back and looked at the patient 3 weeks earlier, you will see they were in the ER with pharyngitis and adenitis, and this is Lemierre syndrome. Lemierre syndrome is thrombophlebitis of the internal jugular vein resulting in metastatic sepsis. This most commonly goes to the lungs, but it can go to any organ. It is typically preceded by oropharyngeal infection, a peritonsillar or retropharyngeal abscess. And while it does have a predominance in men, in early adulthood, please be clear, it does not spare sex and it does not spare any age group. It is caused by the anaerobic gram-negative Bacillus Fusobacterium necrophorum. And here are some other examples of Miss Lemierre syndrome. 61-year-old male with acute febrile illness. We'll see the retropharyngeal edema or effusion, the clot in the jugular vein, clot in the jugular vein here, and the septic emboli. And a different patient that came in within 2 weeks of the patient I just showed you, a 43-year-old. Here you'll see the clot in the internal jugular vein going down the neck. And then you'll see the large retropharyngeal collection, and on the chest portion, the wedge-shaped septic pulmonary emboli. So take-home points: the differential diagnosis. Frequently, the neck site T may be looked at in isolation, and it may be read as or isolated oropharyngeal infection or isolated venous thrombosis with cervical adenitis, pneumonia, and occasionally the lung lesions are read as metastatic disease. It is important to remember, when you see lung disease, when you see oropharyngeal infection, when you see internal jugular vein thrombosis, to go back and make sure you're not missing Lemierre's disease. You need a high index of suspicion. This is a radiologic diagnosis. We can make a difference. And if you don't think about the diagnosis and you await cultures, it may be too late. Up to 10 to 15% of these patients die. They need urgent IV antibiotics, hydration, and many people are treated with anticoagulation, though that is more controversial. This is a different patient that came in and had difficulty swallowing, a sore throat. They were given the diagnosis of pharyngitis, but I think we all can see that there's a markedly edematous epiglottis here, extending into the aryepiglottic folds and the preepiglottic fat. And on the scalp topogram, which should always be the first place you start when you look at these studies, you see the massive thumbprint from the epiglottis, and this was strep pneumonia epiglottitis. Epiglottitis, it's important because in adults, it may present as pharyngitis. It can be caused by infection, but also chemically, either through thermal injury, allergies, or even trauma, including intubation. Management should be treating the underlying cause and allowing our clinical colleagues to manage the airway. Here's an example of a nifedipine allergy with swelling of the aryepiglottic fold here. This is a 24-year-old outpatient that was being imaged for bilateral neck masses, and the initial diagnosis by the trainee was bilateral parotiditis. But if you look very closely, yes, there's enlargement of the bilateral parotid glands and the submandibular glands, but you will also see extensive swelling of the epiglottis and the aryepiglottic folds, and look at the extensive reticulation of the subcutaneous fat, deep and superficial to the platysma muscle and throughout the tissues of the neck. And this was anaphylaxis from IV contrast. So we're going to spend the next portion of the talk dealing with interpretive errors and misses in head and neck cancer. This is a subject near and dear to my heart, and not too long ago, just under 20 years, I did a large study looking at reinterpretation of cross-sectional images in the setting of a multidisciplinary cancer center. We looked at 136 patients at our cancer center with clinicians present. They all had outside images. And after we reviewed them in the cancer center, we went back and reviewed the outside images and compared the interpretations. What we found was that 56 of 136 patients, or 41%, had a change in interpretation. 46 of the 136, 34% had a change in TNM. And of the image interpretations, treatment was affected in 55 of the 56, or 98%, and prognosis in 95%. It's important to note that the change in diagnosis, the verification, was done pathologically in 75% of patients. In 18% of patients, it was based on characteristic imaging findings, and in 7% of patients, it was confirmed through clinical or imaging follow-up. Now, the interesting thing is, if you look at the literature that's out there, and I gave you references at the end of this talk, it'll tell you that 60 to 80% of all imaging errors are perceptual, but in the head and neck, I really do believe that many of these are much more likely to be interpretive. And when I went back and looked at our study for perceptual errors or blind spots, only 27% represented perceptual errors. There were 6 missed second unrelated primary tumors, 2 patients with distant metastases that were missed, 7 missed isolated nodal metastases. But the interpretive errors, the blind knowledge, the errors where the finding was seen but not interpreted correctly, represented 73% of this patient cohort. So this is a 54-year-old woman with headaches and facial pain. The initial read was normal. I'll give you a second to look at it. But if we go back and we get additional history, we see that the pain was on the left and it was associated with numbness, that she had forehead weakness, ptosis, and if you went back in her medical records 1 to 2 years earlier, she had a sore spot and numbness on her left eyebrow. Going back now and looking at the images, these are the superior ophthalmic veins, and here we see perineural tracking along V1. This is normal V1 on the right. And we see that it goes to the orbital apex and tracks back into the cavernous sinus. And down here we see tumor in foramen rotundum, tumor in the pterygopalatine fossa, and tumor in foramen ovale. And here is the normal side for comparison. You can see the nerve. And what was also missed was the atrophy of the muscles of mastication. Remember, the motor branch comes off of V3 and ovale, and here you see the atrophy of the muscles of mastication. Looking in the coronal plane, see tumor going from the supraorbital foramen along V1. Here we see it tracking. It goes back to the superior orbital fissure to the cavernous sinus, and don't forget the spreading into foramen rotundum. So when we talk about perineural tumor spread, it is almost always along cranial nerves 5, then 7, then 12. And you'll have to go back and look at the primary locations. You just can't look and say there's a lesion on a nerve. You have to go back and say, where is it coming from? The areas that you want to pay close attention to are the skin, the nasopharynx, and the paranasal sinuses. So this is a patient with neck and jaw pain. The initial read of this was normal, and this is an in-your-face miss. If we look very closely, we see tumor in the pterygopalatine fossa, normal fat on the left, tumor in foramen rotundum, normal fat on the left, tumor in the inferior orbital fissure, normal fat on the left, and here the tumor has gone back to the eye, and now you see the mass in the nasopharynx, this 8-millimeter mass in the nasopharynx, and this reread is nasopharyngeal carcinoma with perineural tracking. This is a patient with an inverting papilloma with squamous cell carcinoma. We see the destruction of the bone in the forehead. The patient had surgery. We see the nice clearing of the sinonasal cavity and the surgical changes. And 9 months later, the patient came back with a left sixth nerve palsy and a mass in the cavernous sinus. When you go back and you look at the 3-month postoperative imaging, we see the missed perineural tracking along V1. Remember, this lesion is near the supraorbital foramen, and this patient succumbed from their cancer. This is another example of missed perineural spread along V1. This patient had adenoid cystic carcinoma. We see the surgery, and everybody was so focused on how nice the sinuses looked and that there was no recurrence there that they forgot to look at V1. And again, here, V1 and the trochlear nerve in the axial plane. Now remember, lymphoma likes to spread perineurally also. This is a patient that had orbital lymphoma, and this is recurrent lymphoma in the inferior orbital fissure, the foramen rotundum, the pterygopalatine fossa, and here we see the restricted diffusion at the pterygopalatine fossa. This was a 52-year-old with hoarseness, had a neck MRI done that was interpreted as normal, had a head CT where this was read as a lesion on the arytenoid. Patient went on to get a PET CT, and here we'll see the obvious FDG avid lesion in the aortic pulmonary window. In retrospect, there is a mass in the aortic pulmonary window on the MRI, albeit I will tell you this is a very difficult area to assess. And when we rethink the imaging, this is vocal cord paralysis, right? Dilatation of the laryngeal ventricle, medialization of the fold, and the patient actually has compensatory uptake in the right true vocal cord. This was actually misinterpreted on the PET CT as a right cord lesion, but this is compensatory uptake in the right cord due to left vocal cord paralysis from small cell carcinoma in the aortic pulmonary window. Remember, the recurrent laryngeal nerve courses underneath the aortic arch here. This is a patient with dysarthria and dysphagia. This was signed off as a mastoid and middle ear effusion. If we go back, we can see there's enhancing mass in the jugular foramen growing into the sigmoid sinus. Compare it to the opposite side. We see an enhancing mass in the middle ear cavity. And here we see what looks at first to be a normal jugular vein. Here is the normal left side for comparison. But when you look at the T2 weighted imaging, you'll see the absence of the normal venous flow void. This is the normal left side for comparison. And within the tissue in the right internal jugular vein, you will see flow voids. This is a missed glomus jugulare tympanicum. And 6 months later, the patient came back with interval hoarseness. Here we see sequela. Now they've got a vocal cord paralysis on the right, dilatation of the laryngeal ventricle, medialization of the arytmoid. They've got a spinal accessory denervation, volume loss of the sternocleidoid mastoid and the trapezius muscle, and fatty replacement of the oral tongue from a tongue paralysis. And we can see now there's enlarging mass in the jugular foramen and the marked extensive growth going down into the internal jugular vein. This is a patient. The PET CT was read as recurrent masses in the left neck. If we look at the enhanced CT, we'll see partial surgical absence of the sternocleidoid mastoid muscle, but you will see volume loss or denervation, of the trapezius muscle. And this represents compensatory uptake in the scalene muscles from spinal accessory denervation. This is a 29-year-old with a tongue mass and dysarthria. The initial diagnosis was a left base of tongue mass, and the interpretation came because there was this clear asymmetric fullness of the left base of tongue. I saw the images and got some additional history, which was that 2 weeks earlier, this patient was hospitalized for asthma and prolonged coughing. So what you're looking at here really is left tongue paralysis. And because that wasn't initially detected, the perceptual errors, other misses were an enlarged right internal carotid artery and an absent flow void in the left internal carotid artery. And here you will see, I went on to get the CT. This is the pseudoaneurysm and dissection of the right internal carotid artery, normal lumen. And you'll see the pseudoaneurysm here, the relative absent flow in the left internal carotid artery. Here we'll see the string-like flow, the pseudoaneurysm, and this large mural hematoma. So these are bilateral internal carotid artery dissections with pseudoaneurysms from the patient's prolonged coughing. And remember, the 12th nerve runs between the internal and external carotid artery, and this pseudoaneurysm on the left resulted in the patient's left tongue paralysis. This is a 63-year-old with 2 weeks of dysarthria, went to the emergency room, had tongue swelling, and was given the diagnosis of angioedema clinically. They went on, I'm not sure why, to get an MRI, but the MRI was interpreted as a base of tongue carcinoma. Now, if we look very closely, we'll see what I call a very geographic abnormality. And it's important to remember that when you see this, you should be thinking about denervation. We see protrusion of the tongue base into the path of least resistance, the oropharynx. It's important to remember that in the acute setting of denervation, the first 2 to 3 weeks, the tongue actually swells. It may enhance, and it has abnormal signal. As you see in this case, and here on the T1, we see the absolutely normal architecture. There is no mass. So this is reinterpreted as a right tongue denervation. You are not done. You need to go back and track the 12th cranial nerve. So the other finding that was missed was a lesion of the occipital condyle here. You see it extending into the jugular foramen, and you'll see it extending in here to the hypoglossal canal, paralyzing the 12th nerve and resulting in this denervation. So this is metastatic prostate carcinoma to the occipital condyle with secondary tongue denervation. This is another metastasis to the occipital condyle. I just recently saw this case. Here's the occipital condyle with tumor. This is the normal side with the lateral massive C1 for comparison, and in the axial plane, again, the missed metastasis, in this case lung carcinoma of the occipital condyle. This is a missed metastasis in the clivus. It was picked up a month or two later when the patient came in with a right 6th nerve palsy, and here you see the enhancing mass in the clivus. This was a lesion in the clivus in a 42-year-old with headaches that was interpreted as a metastasis. You see the enhancing mass here. It's dark on T2, and that should be a little bit of a pearl when you see that, to think about fibrous dysplasia. And this was a clear diagnosis made with the CT imaging. This is another patient with a mass anterior to the temporal lobe. This was interpreted as a meningioma, but this too is fibrous dysplasia, the diagnosis nicely made on the corresponding CT image that was performed a few months later. Now, this was a 19-year-old with CT that has periosteal reaction, and the initial read was a meningioma. Just want to caution people to reconsider the diagnosis of a meningioma in a 19-year-old. And here, when you look, there's pretty aggressive periosteal reaction. Sometimes we see this in the sphenoid wing. But again, in a 19-year-old, you really need to think about other diagnoses. This was an Ewing sarcoma. And just to finish up, another mass of the clivus that was interpreted as a chordoma. People saw the high signal intensity there. But you'll see on the cisternogram, which probably should not have been performed, that the correct diagnosis here is a meningocele, not a chordoma. So in summary, take-home points. To err is human. We all misinterpret. It's part of being human. These are some strategies to reduce errors. We must have an organized pattern of film reading. Everybody knows when I'm reading films, I start with everything on the film except what the study is being done for. Then I go back and look at the areas of interest. You have to have a personal checklist of your own blind spots. What does that mean? We all have these just areas that we miss that has to be on your regular checklist. You need to make sure that the history is accurate. And every time you get fixed on an obvious finding or an obvious diagnosis, please remember the satisfaction of the search and do your search of the rest of the images. Review prior related imaging and reports, but only the reports after you are done perusing the current study so that you are not biased by something that may be inaccurate in that report. The last thing we want to do is to propagate errors in prior reports. I see this happen all the time. It's such a pet peeve of mine. Please only look at the reports after you've looked at the imaging. If you've been distracted, re-review the study from the beginning. Start over. If you're tired and it's an outpatient, save it for later or tomorrow. And if it's an inpatient, you've got a colleague nearby, ask them to take a look at the study. Artificial intelligence, don't be scared of it. It's here to help us, and I do believe over the next decade we're going to see it helping and correct a lot of our perceptual errors. We will always need radiologists for interpretive interpretations of imaging, so do not fear this. This is here to help us, and I'd rather refer to it as augmented intelligence. This is a good thing. Communicate, communicate, and communicate. You have to have concise reports. You can't throw a laundry list at them. You can't give a lot of description. It just confuses clinicians. It may actually hurt the patient. And if you don't know what's going on, it's better just to say you don't know. Your clinician will appreciate that very, very much. It's important to communicate. Speak to your referring physicians when something doesn't make sense or when you don't have accurate history. And speak to your patients. I'm on FaceTime on my iPhone with at least 3 or 4 patients every day, especially films coming in from outside providers, patients outside the health system, clinicians outside the health system that have referred their patients to Penn for imaging. I have no problem picking up the phone to call the patient to get a history, and they are very, very appreciative of it. Quality and safety committees. All departments, private and academic, should have these to review and track mistakes and to correct system errors. And when in doubt, check it out. Consult your radiologic partners, get a second opinion, and consult the subspecialists that you work with in other areas. I hope you have found this subject to be interesting. I very much enjoyed putting the talk together. This really is a passion of mine, and I very, very much enjoyed being able to participate. Everybody have a great ASHNR. Thank you again for including me. Everybody stay well, be well. Thank you.
Our next lecture will be given by the excellent and always entertaining Dr. Phil Chapman from UAB, who will be speaking about what does not fit, tips for the correct diagnosis.
Hi, I'm Philip Chapman at Duke University, and the title of this talk is Something Doesn't Fit. Subtitle is Uncomfortable Clues to Uncomfortable Diagnosis in Head and Neck Imaging. I have no disclosures, and for the objectives of this talk, I'm going to basically provide a case review in which there were some unusual or difficult cases in head and neck imaging. We're going to review cases in which some findings or some factors did not seem to fit with a suspected or a known diagnosis. We're going to analyze how these unusual findings or unusual factors might be misleading, and then we're going to try to recognize when an unusual or unanticipated component of the case requires a pivot in our thought process and a new direction in a working diagnosis. So the first case we're going to look at has to do with bilateral eyelid swelling. This was a 45-year-old female who presented to the ophthalmology service with a chief complaint of bilateral eyelid and periorbital swelling, right greater than left. Additional information: the patient had a known malignancy. She had presented 2 years previously with a vulvar squamous cell carcinoma with bilateral inguinal adenopathy, and for that she was treated with surgical excision and also underwent radiation therapy and chemotherapy. Just backing up briefly, you can see that there's this area of nodular enhancement in the superolateral aspect of the orbit related to the right lacrimal gland. Here are a couple of axial images, contrast enhanced CTs through the orbit. You can see that there's mild enlargement of both lacrimal glands, right greater than left, and there is some mild stranding adjacent to the lacrimal glands, suggesting some adjacent periorbital inflammatory change. Here is the coronal view, again reflecting some of those similar findings on this contrast enhanced view. Now, when I think typically of bilateral enlargement of the lacrimal glands, there are a number of things that come to mind for me, and I'm sure for you as well. And one is idiopathic dacryoadenitis. There's an autoimmune version. This includes sarcoidosis, Sjogren's, IgG4, and even GPA. And then there are some lymphoproliferative disorders that can present with bilateral enlargement of the lacrimal glands, including lymphoid hyperplasia and lymphoma. Now notice metastatic disease is not on this short list, and we'll come back to that discussion. Now it turns out that prior to the CT that I interpreted, the patient had a previous multiple PET scans, and you can see this started shortly after her diagnosis, and you can see there's some bilateral inguinal adenopathy, and about every 6 months she was re-imaged again with PET scan showing clearing of that adenopathy originally, and then early in 2019 there was a suggestion of interval redevelopment of right-sided inguinal adenopathy. Now, one of the things that struck the molecular imaging specialist is that in 2019 she developed a fairly short-term interval change in the PET scan, and this is what it looks like 5 months after the early scan in 2019. So you can see there's marked hypermetabolic activity in mediastinal and hilar nodes. There's some pulmonary nodules that are showing hypermetabolic activity. There's some cervical adenopathy, and then we have these areas of hypermetabolic activity in the orbits as well. Now, on this particular scan, it was interpreted as metastatic disease was favored. Now, there was a discussion about other things such as sarcoidosis and lymphoma, but given the course of events and the history in this patient, this was concluded to represent metastatic disease on the CT PET evaluation. So when I read the CT, contrast enhanced CT of the orbits, I guess I was caught up in the moment, caught up in this discussion about metastatic disease. and I basically described the mild enlargement bilaterally, and then I took into full consideration this interpretation of the PET scan, and my impression essentially said bilateral lacrimal enlargement, and generally we would consider sarcoidosis or lymphoma, but given the appearance on recent CT PET scan and extensive metastatic disease involving the lacrimal glands would be favored. So I think you can already get the sense that I'm trying to squeeze an uncomfortable diagnosis into a square diagnosis, if you will, into a round hole here. Turns out this patient underwent biopsy of the lacrimal gland, biopsy of the cervical lymph nodes, as well as biopsy of the pulmonary nodules, and each of these revealed the same pathology. These were non-caseating granulomas consistent with sarcoidosis. It turns out that the patient was put on a course of steroids, and this led to rapid improvement. Now, as I look back at this case, I certainly can look at this lacrimal gland enlargement, and I can see that my suggestion of bilateral metastatic disease was certainly uncomfortable. It was an uncomfortable fit. Obviously, sarcoidosis would be high on the list. Lymphoproliferative disorders such as lymphoma would be high on the list. And as I think back even now, I'm not sure I've ever seen another case where there was a fairly uniform metastatic disease involving the lacrimal glands. So it certainly was an uncomfortable fit. Now, all of us have seen diffuse metastatic disease in situations where there's end-stage malignancy, and those metastases can occur virtually anywhere, including the extraocular muscles, including the bones of the organ, including the fat and lacrimal glands. But this uniform appearance would certainly be unusual. The other thing I think that I thought was an uncomfortable fit for me is I'm used to thinking of sarcoidosis as sort of a long-standing, smoldering or indolent process that we might come across incidentally on imaging, and when we're doing head and neck cancer imaging. A common example is we see a patient with, say, a T1 lesion, no lymph nodes in the neck, but the patient has nodes in the mediastinum that turn out to be related to sarcoidosis. So it's not an uncommon process, but for me, this transition from relatively quiescent disease to really marked active disease with new pulmonary nodules, that was a new a new thing that I had to kind of wrap my head around. But again, not a comfortable fit for me. Now, in terms of sarcoidosis and this idea that this can mimic malignancy, this has obviously been discussed. It's a common dilemma in the world of nuclear medicine in particular. So it's not something that's really new. We see patients with cancer and also have simultaneous sarcoidosis. We also have patients who have sarcoidosis who develop cancer, and then we have patients who have cancer and develop sarcoidosis. And there's some interesting theories about that. But certainly we do recognize that there's coexistence of sarcoidosis in the setting of metastatic disease sometimes. Here's a companion case just to show you an example of active sarcoidosis that affects the orbits. You can see there's nodular enhancement in the adnexal regions, in the medial canthal regions, extraocular, and it looks like in some of these cases it involves the extraocular muscles. And also notice in this particular case, there's marked involvement of the intracranial compartment as well. There's dural disease. You can see lesions tracking along the tentorium on the right, and on the left there's disease involving the uncus. Looking down in the spine, there's additional areas of involvement in the mid-thoracic spine as well in this patient with diffuse systemic sarcoidosis as well as neurosarcoidosis. And then of course in this same patient there's a typical involvement, subcarinal adenopathy, bilateral hilar adenopathy, and some nodules in the lungs as well. When it comes to head and neck sarcoidosis, again, we usually think of it in the orbit, interpretive anterior uveitis, but it can affect the lacrimal gland, can affect the orbit and the optic nerve. There are sinonasal lesions that affect our CT of the sinuses and MRIs of the facial bones. There are skull-base lesions. Here's a patient with skull-base sarcoidosis with destruction of an invasion of the petrous apex in the adjacent cavernous sinus and Meckel's cave. There can also be parotid and lymph node involvement as well. So let's look now at another case of an infiltrative lesion of the orbit. This is a 52-year-old female presented to an outside hospital with left eye discomfort. She had some mild pain of the left orbit and also had double vision. She was diagnosed clinically with restrictive strabismus, and there was no pertinent previous medical history. Here's an axial T1, and I'll just bring your attention to the left orbit and specifically the medial rectus muscle. It looks like it's enlarged throughout the muscle belly. There's a little bit of stranding in the fat medial to that, and then the inferior rectus muscle is also slightly enlarged. Here's post-contrast fat-saturated images through the orbit. Again, you can see enlargement of the medial rectus muscle. There's enhancement of the muscle itself, as well as some subtle enhancement in the fat medial to it. And seen less well is the inferior rectus muscle, and I'll show you the coronal views here. We'll just go from front to back just to kind of go through this quickly. You'll see there's some enlargement and enhancement of the medial and inferior rectus muscles. Here's the coronal post-contrast images again. Again, the arrows just emphasize enlargement of the inferior medial rectus muscles, but there's also some stranding in the adjacent fat within the intraconal space on these particular images. So given that the patient had some pain and some restriction of movement, she was given the diagnosis of a nonspecific orbital inflammation or idiopathic inflammation of the orbit. Some people use the term pseudotumor for this, and I think this fits, at least initially, because it's the most common painful eye disease. It can be localized or it can be diffused. It's often unilateral, and there is a particular myocytic form that results in this painful diplopia, and there's restriction or impairment of extraocular muscle movement. In these cases, steroids tend to create prompt improvement when they're used, and this is ultimately a diagnosis of exclusion. A lot of times these patients will go to actual biopsy to exclude neoplasm or some other involvement of the orbit, but it's a reasonable working diagnosis, at least initially. Now, in terms of follow-up, after 2 months of steroids, the patient continued to have pain. There was continued restriction of motion in the eye. The patient continued to have double vision, and so in fact she was actually doing worse. So it turns out this diagnosis, it doesn't fit too well anymore because we've tried steroids, and in fact the patient did not respond as most patients do. She actually got worse. So at that point the patient was referred to an ophthalmologist, and the original MRI was reviewed by a radiologist at the outside hospital, and in their review they basically described fusiform enlargement of the medial and inferior rectus muscles with sparing of the tendinous insertions. Given this pattern of involvement, thyroid-associated orbitopathy is favored, and the differential diagnosis is, of course, idiopathic inflammatory disease. So it switched then to a new working diagnosis of thyroid ophthalmopathy, and it brings to mind this mnemonic, this classic mnemonic that was taught to most of us of "I'm slow," and this really just refers to the propensity for extraocular muscle involvement in thyroid ophthalmopathy, beginning with the most common inferior rectus, then medial rectus, superior rectus, lateral rectus, and the oblique, superior oblique, and then the W is just there to complete the mnemonic of I'm slow. Perhaps W means I just want to pass the board so I can go to work. But that's the mnemonic that we're all familiar with. And we do know that with thyroid ophthalmopathy, you can see asymmetric disease. So I think that's a reasonable consideration once we dismiss this idea that this is inflammatory, idiopathic inflammatory disease of the orbit. Here is an example of an asymmetric thyroid ophthalmopathy. This is a 67-year-old female with Graves' disease. She was diagnosed 1 year earlier, and then she was treated with thyroid ablation and was now actually hypothyroid, and she presents with painless proptosis, and this is the diagnosis in this case. You can see enlargement of the inferior rectus muscle, enlargement of the medial rectus muscle, and there is in fact a little bit of stranding in the adjacent fat. So when we consider this diagnosis, I think it's at least reasonable. Now it turns out this patient in our sentinel case here, there's no history of thyroid disease. The thyroid markers were performed, including TSI, and they were all normal. So we're back to having a diagnosis that doesn't fit. Now, I do understand there's a rare diagnosis out there of euthyroid Graves ophthalmopathy, or EGO, so we're not going to go down that trail today, but I know some of you are probably thinking about that. Finally, a follow-up MRI was performed, and I'm going to show you those images now. And at this point, you can see there's increased enhancement, increased nodularity and mass effect in that medial rectus muscle. The intraconal fat is now even infiltrated to a greater degree. And then if we look at the coronal view, you can see there's nodular and mass-like enhancement in those extraocular muscles, but also in the intraconal fat, and even some extraconal involvement as well. And then you can also see that there's a new lesion in the brain in the right frontal lobe that's concerning for metastatic disease. Additional images through the brain show additional foci of metastatic involvement in this case, and this is an example of metastatic breast cancer to the orbit. In this case, this patient presented with painful ophthalmoplegia as her initial presentation of breast cancer. There was no indication that she had breast cancer either clinically or historically prior to this. Now, metastatic breast cancer to the orbit is relatively rare. In fact, the orbit is a relatively rare site of metastasis in general. Most metastases to the orbit occur with a known diagnosis of malignancy. At least one paper I found suggested that about 20% of the time metastasis to the orbit could be a presenting symptom. I think that's fairly high, and maybe there was a selection bias in this particular patient population. It's typically unilateral. When it's bilateral, it's usually very asymmetric. But these patients present with orbital pain, edema, and proptosis most commonly. Now, before leaving this case, I will show you another classic case, and it's also a case that often it has trouble fitting in with our concept of what metastatic disease should do, but it's the serous or scarous metastatic breast cancer to the orbit. In this case, you can see this is a 45-year-old female. She originally diagnosed with stage 4 breast cancer, bilateral breast cancer, with positive bilateral nodes 5 years earlier. Now she presents with painless anophthalmos, and you can see that the right globe is actually displaced posteriorly. There's some abnormal signal in the retroorbital space, as well as abnormal enhancement, and you can see there's nodular enhancement within the right orbit, and involving the extraocular muscles, and also involving the intraconal fat. And this is it's so unusual for us to see, but we see it enough to where we ought to recognize it as one of the manifestations of metastatic breast cancer, where we actually lose volume volume as there is a contraction of tissues in the retroorbital space in response to the breast cancer. Let's look at another case in which the original working diagnosis required a fairly tight fit. This is a 62-year-old with a 12-month history of progressive, painless, upper and lower eyelid swelling and some blurred vision. Here is coronal reformats from the original CT scan that was done, and I think you can appreciate there is enlargement of the extraocular muscles, and that seems to be the primary finding. There are some other subtle areas of soft tissue density and enhancement outside of the extraocular muscles, but the primary finding seems to be related to the extraocular muscles themselves. Here's just a couple of axial contrast enhanced CT images through the orbits in that same patient, and the initial reader really got locked into the extraocular muscle enlargement and involvement, and concluded that there's diffuse bilateral extraocular muscle enlargement with exophthalmos, and the findings are suggestive of thyroid ophthalmopathy. And I think if we look at this, especially if we only take into consideration these two images here, you can see that there is indeed enlargement of the muscle bellies. This seems to taper so that the tendons do not appear to be involved. There doesn't appear to be significant nodularity or mass effect in the intraconal space, and not much stranding there. So I think that's a reasonable diagnosis, at least initially. Here is just a graphic illustrating that extraocular muscle enlargement that we spoke of earlier. Here's a typical MRI scan. I think we maybe have overdone the red arrows here, but the point is most of the extraocular muscles are enlarged in this patient, and they're symmetrically enlarged, and this is a fairly typical appearance of thyroid ophthalmopathy. When we come back to our case, it turns out that our patient had no history of thyroid disease. The thyroid function tests were normal, so the diagnosis doesn't really fit. So we've got to pivot and try to go a different direction in terms of what we're thinking. It turns out, as we may have mentioned on these first set of coronal images, some of the image details don't fit either. And in this case, we can clearly see that there's involvement of the extraocular muscles, but there's too much soft tissue density outside of those extraocular muscles, both in the extraconal space and in the intraconal space, as well as some involvement of the left lacrimal gland in particular, possibly the right, but certainly the left adnexa is involved here. Now, the MRI was performed a couple of months after the CT, and I think we would all agree that at least the findings are stable, if not worse. Here's the coronal T1s in this patient, and you can see again enlargement of the muscles, but then nodular soft tissue signal in the intraconal space and extraconal space, and along the region of the left adnexa involved in the left lacrimal gland. Post-contrast images show marked enhancement of the extraocular muscles, and then all of this extra muscular soft tissue also enhances within the intraconal space as we would expect it to do. So when we think about this extraocular muscle enlargement, that was sort of the primary emphasis of the original reader. Obviously, the more common things are thyroid-associated orbitopathy or idiopathic orbital inflammatory disease. But again, the patient did not have significant pain, so we would probably discount the second thing on the list as well. Less common things that occur are lymphoproliferative lesions, including lymphoma, but also metastatic disease, and then we can see that with trauma lymphoma and cellulitis, and sarcoidosis is another strong consideration, I think, in this particular case. But this was ultimately diagnosed, and biopsy was performed, and this was a malt lymphoma, or mucosa-associated lymphoid tissue lymphoma that involved both orbits. And in fact, you could have argued on that original CT that there was preferential involvement of the extraocular muscles, although those details might argue against that a little bit. But this was a little bit of an unusual fit for me. I'm used to seeing lymphoma in the orbits and certainly involving the lacrimal glands, but not this symmetric diffuse involvement of the extraocular muscles. Here are just some other cases of lymphoma, the orbits, non-Hodgkin's lymphoma, where there's a large eccentric mass or asymmetric mass. Here you can see two different patients. Here's another patient with a large orbital, sino-orbital mass, and then another patient with extensive nodular enhancement that actually looks like it spares the extraocular muscles in this case, and primarily involves the intraconal and extraconal fat. But this was, again, an unusual lesion that was initially thought to represent thyroid ophthalmopathy due to its primary involvement of the extraocular muscles, and also due to its symmetry as well. So in the last couple of minutes, I'll just leave you with a point that will be made probably many times throughout this conference, but this is in regards to a cystic mass in the neck. This is a 35-year-old male with a palpable lateral neck mass. It was shown to be cystic by ultrasound. You can see the contrast enhanced CT appearance. It certainly looks like it's fluid filled. It's well circumscribed. No real nodular or mass-like enhancement related to this lesion. And this was dictated as a probable second branchial cleft cyst. Well, the patient left the emergency room, but then returned 7 weeks later. The lesion was now angrier. You can see the wall is thickened. It may be superinfected. It's hard to know, but it's certainly inflamed at this point. And this was dictated as now an infected second branchial cleft cyst with associated increased right neck edema. It turns out the diagnosis in this case is a familiar one, and this was cystic nodal metastasis related to radiologically occult HPV-positive tonsillar carcinoma. So in this conference, you'll see this over and over, but it brings me to sort of a chalkboard moment here that branchial cleft cysts don't fit in adults, and need to try to remember that. Or another way of saying that is a new cystic neck mass in an adult is a cystic nodal metastasis until proven otherwise. This is just another example of a similar type case, but you can see this nodal metastasis, how necrotic and cystic it is. Yes, there are a couple of little septations within it, but it's predominantly cystic, and these things can mimic a second branchial cleft cyst. Now, I'm going to show you the second branchial cleft cyst, but I'll just reiterate that for me, this is a very uncomfortable diagnosis. It's very uncomfortable, and in fact, it's very difficult for me to even say these words, second branchial cleft cyst, in a report. But this was biopsy proven, and in my point of view, there needs to be biopsy proof of a second branchial cleft cyst before we're going to rely on that diagnosis. Otherwise, anything that looks like this in a middle-aged or elderly person is a neoplasm until proven otherwise. So in conclusion, we've reviewed some challenging diagnosis, and we've examined the process of changing a working diagnosis as new information becomes available. And I would just remind you that don't always be inclined to force a square finding into a round diagnosis. In other words, don't force yourself into a limited differential if there are things that don't fit. Remember, it's our job to investigate further when pieces don't fit. So if there's some detail in the imaging, some detail about the history or the pathology that doesn't fit with what you're seeing, then make that known, at least in the body of the report. Flush out a differential for those things, and maybe recommend appropriate follow-up. Thank you.
And our final speaker for this session on staying out of trouble is Dr. Doug Phillips from Weill Cornell Medical College in New York, who will be speaking to us about reporting do's and don'ts, malpractice challenges.
Hi, my name is Doug Phillips. I'm a professor of radiology at Weill Cornell Medical College, and I am an attending physician at New York Presbyterian Hospital. It is my pleasure to lecture here at the virtual ASHNR meeting in the year 2020. My thanks to Ilana Schmalfuss and the program committee for the invitation. I hope you're all enjoying the lecture so far. My topic today is head and neck radiology, reporting do's and don'ts, malpractice challenges, and this is a little bit of a switch up for me, but a topic that I have considerable interest in. I have no pertinent financial disclosures. I will not profit from giving this virtual lecture. Every topic I've ever been asked to speak on, I like to look into the history a little bit, delve in to see what that's all about, and didn't do anything differently here. The history of malpractice is essentially as lengthy as the history of medicine. Malpractice derives from the Latin term mala praxis, which was subsequently defined to refer to negligent or unskillful management by a physician. How physicians are dealt with when they commit errors has been, again, a long and convoluted history, but one of the more interesting kind of diversions of all this was from the Code of Hammurabi. The background of this slide is actually one of the stones of the Code of Hammurabi. Hammurabi said that medical errors were criminal offenses, and they were dealt with in a serious fashion. There are very serious punishments for medical malpractice, including amputation of a surgeon's hand for poor outcomes. Now, we've moved a little bit beyond that, but many people who've been through malpractice events say it's probably not a whole lot dissimilar, at least psychically. I've also thrown some quotations through here because I like them. You'll just have to deal with them. This is one of my favorites from the book of Luke. Woe unto you also, you lawyers, for ye lade men with burdens grievous to be borne, and ye yourselves touch not the burdens with one of your fingers. And that's pretty harsh. So here we go. The objectives of our next 25 plus minutes, we're going to discuss the radiology report. What is that report? We'll describe it and define it as our patient care utility document, and we'll discuss the medical legal responsibility that goes along with generating that report. We're going to talk about some common errors in reports that leave the potential for liability, things like critical findings, unexpected findings, limitations of the examination, and others. Quote number next, famous proverb, he who is his own lawyer has a fool for a client. I've dealt with a lot of lawyers over the years and dealing with malpractice issues. I think most of them are very good folks and are truly concerned about a just outcome for things, both for their client and kind of overall in the case. But everybody's arguing a single point, and that's the deal. Malpractice claims in the United States of America. Common reasons. These are the top three, which represent over 98% of claims filed. Number one, obviously, error in diagnosis. The lesion wasn't seen, it was incorrectly categorized, wasn't acted on, but there's a primary miss somewhere in the chain. Number two is the lack of adequate communications with the referring physician. And again, our radiology report is the basis of our communication with the referring physician about the findings on our examination. But there are other ways that we can communicate, and we'll talk a little bit about some of those. Number three, interestingly, failure to recommend additional testing. And that is obviously an important element in radiology reports, and I think that leads us to our next topic, and that is, what are our standards? What does our organization say we should generate in a report? And that to the ACR standard for communication. The ACR standard for communication is a very detailed but very concise document that it breaks out for us what elements should be in a radiology report, how they should be presented, what should be emphasized and what shouldn't be emphasized. So This is the entirety of what comes into a standard diagnostic imaging report, the review of the patient demographics, the relevant clinical information that leads to the exam, the procedures and materials, what you did, the findings. According to the ACR, what should go in the findings are appropriate anatomic, pathologic, and radiologic terminology to describe the examination. So essentially, in that part of the report, we're going to talk like a radiologist. The report should also list limitations of the examination that we did, the clinical issues that we find to be appropriate in generating this report, comparison with prior studies and other reports, other data that you may have, and then finally, the impression. So if in the findings of the report, we talk like a radiologist, in the impression, we talk like a clinician talking to another clinician or perhaps to the patient about what the significance of our findings are. So the findings, a high-density extraaxial collection that's crescentic in shape. The impression, there's a subdural and it's causing herniation. There are general considerations, obviously, medico-legally in the head and neck that are no different than any other area of anatomy, and there are some special considerations as well. So let's just briefly talk about some of the general considerations in head and neck reporting. The ACR is all over the idea that appropriate content should be in the report. It's self-obvious, very true. The report should be meticulous, but it should be concise. It should contain appropriate abbreviations, things that are well documented and that everyone would understand. Don't make up your own. As well as the pertinent positives the examination may reveal, pertinent negatives are also thought to be important in a report. Obviously, comparison with old studies. Document that. Things have changed, things haven't changed, or this new lesion is determined to be of significance. Accurate terminology is a key element in reporting, I think common sense-wise and also as described by the ACR. Ambiguous vocabulary is a huge problem overall. You probably won't be forgiven for missing a tumor that you felt was subtle and proclaim no gross tumor, obviously. But things like overt, obvious, apparent, no gross, or no evidence of, or nothing significant, they're all terms that we use. Borderline is like one of my favorite terms that people use for describing lymph nodes. But remember, in the setting of a head and neck cancer, it's binary oral. Tumor yes, tumor no, 0 or 1. And you have published data to fall back on. That intermediate SUV is an intermediate SUV. It's not a positive SUV. If you think tissue sampling should be performed, then you can stipulate that. But the report should avoid this terminology that just becomes maddening overall. Avoid modifiers when there is no standard, and that can be very tough. So modifiers are things like septal deviation or burden of sinus inflammatory disease. If you say there's mild, moderate, or severe septal deviation, most of us wouldn't know what you're talking about. Mild, moderate, or severe sinus disease, if you refer that to an appropriate staging system, such as like the Lund-Kennedy system, then it becomes meaningful. If there is no standard, the modifiers become very problematic. Avoid double negatives when you can. It confuses you, and it certainly confuses people reading your report. And finally, avoid generalizations. Just some examples, some things that I have taken from some reports that have crossed my desk. Terminology that you should avoid. Level 2 lymph node is 9 millimeters in diameter and is indeterminate. Well, it's 9 millimeters, and that doesn't equal pathologic cervical lymph node unless it's heterogeneously enhancing, and that's not described. So, it's not really an indeterminate node. It's not a pathologic node, not by our imaging study. There's no definite extracapsular disease. Well, there is subtle extracapsular disease, but nothing definite. You can see where that can be very problematic. The inappropriate modifiers and generalizations, again, mild to moderate septal deviation, on whose scale. And this lesion was actually a high-grade mucoepidermoid in the parotid. The descriptor was, this small mass is well-defined and appears benign. Hardly. More in the terms of general considerations, effective communication. And again, number 2 on the list of why people get sued. So generate effective communication. Your report should stand alone, and it should be thorough, concise, and easily placed in context in that patient's clinical setting. Verbal notifications should always be performed when there are acute or urgent findings. And that's obviously a threshold item, but my threshold, I will tell you, over the years has fallen and fallen and fallen. When you communicate with a physician, remember to use encrypted or secure communications. Telephone is great. Get readback verification. Text messages are not either encrypted or secure and should not be utilized. Email may be encrypted, but not necessarily. Always be thinking of HIPAA and the potential to violate any HIPAA regulations. Now, the special considerations in the head and neck. And there are a lot of them, and we're not going to touch on all of them, but a few high points that I got from talking with some colleagues and also things that I have experienced myself. We do a lot of screening sinus CT, that non-contrast low-dose CT for navigation purposes in the OR. They're low technique. They cover a lot of anatomy, however, pretty much all the brain, super high neck. Those are areas that are not our primary area of concern, but are imaged. I'm sure you're going to be hearing from others about the findings to concern yourself with in sinuses, but remember, the entirety of everything on that examination becomes a veritable landmine of medical legal concerns and potential errors. Malignant sinus disease in the setting of a benign sinus presentation, things like encephaloceles, critical anatomic variants, incidental intracranial superhyoid neck disease. That's all things that can come up routinely in evaluating screen and sinus CT. My advice, read from a template. Always know that you have something to kind of hearken you back to the things you may overlook. Know your referrers, communicate with them appropriately, keep a low threshold for phone calls, and insisting on follow-up examinations. There are a million potential things I could show you, but I'll just show you this one. This patient had had a number of screening sinus CT examinations, and this little calcified lesion in a paracellular location was finally described and subsequently imaged. It's a little incidental paracellular meningioma. That's easy, and that's a relatively benign lesion that had not progressed. But imagine malignant disease or missed cerebral aneurysms. Aneurysms, nasopharyngeal carcinoma, primary brain tumors are all potential landmines sitting there in the data on a screening sinus CT. Potential medical legal pitfalls that we need to describe and talk about in our report. Be aware of those things. Another special consideration in the head and neck, and I think this is a particularly problematic area in head and neck imaging, in my humble opinion, the patient who is sent to be imaged with a, quote, palpable neck mass. Now, there's an inescapable fact here, and that is that someone felt this patient's neck and felt a mass. They sent the patient for imaging on the basis of that. So there's a mass there. Your failure to depict the mass doesn't necessarily mean it's not there. Maybe it resolved. Maybe, conceivably, it was never present. Or maybe it's just not the right imaging study. Example for me, submandibular gland lesions. If a clinician feels a hard, firm submandibular gland, regardless of what it looks like on the CT they subsequently ordered, I'm sure there's something there. I like markers that are positioned routinely by the patient with assistance from a technologist or by a nurse can save you. If you don't note a mass on the examination of a patient who has a, quote, palpable neck mass, detail that and tell the referring physician what the significance that you place on that is. Again, if there's a palpable neck mass, there's a palpable neck mass. So there are many ways that we could appropriately describe this. No imaging correlate for the described palpable mass, and imaging could not therefore be utilized to guide biopsy. That's relatively appropriate. To just say no mass, not appropriate. Markers, again, I think save you. They facilitate a confident diagnosis. So at this level in my career, I can say that any patient with a palpable neck mass I don't see is probably a lipoma, but boy, it's really nice when the marker overlies that little focal fatty lesion, as in this case on the left. It can also confirm that what I see and what I consider perhaps the lesion is indeed what was palpated. So this patient was referred for a submandibular mass. There are a couple little nodes there, but that Boutonniere deformity and the odd appearance of the sublingual and submandibular gland on that side confirms that the palpated abnormality is indeed that anatomic deformity. Some pitfalls in reporting, again, touched on this, and let's just dive in a little deeper here. definitive versus inclusive language. When you find an abnormality and you're describing it and now giving an impression about what it means, garbage bag differentials are a frightening thing. So I think it's important that when you come to your impression, you list your top differential points, probably in the order of likely significance. So favor the one that, based on your assessment of the imaging appearance, the clinical information, any other information you may have gleaned from the technologist, the patient, or whatever, lead with that diagnosis. This idea of garbage bag differentials, unhelpful, can be very frightening to patients, can be amazingly confusing to referrers, and basically just overall are very irritating item in radiology reports. This was a patient who was being scanned for an incidental thyroglossal duct cyst. They're in their mid-20s, and they had 3 lymph nodes in level 2A that were very small. And I think you've all heard many of us say, you don't measure normal lymph nodes. But, here you go. What was described in the report: a cluster of level 2A lymph nodes, none of which are over 8 millimeters in size, and enhanced differential considerations include normal nodes, atypical lymphoid proliferative diseases, lymphoma, or reactive nodes. And that does nothing but scare a patient, and it is a pretty worthless inclusion in a report. Garbage bag differentials, I'm sure you've all seen these, and this is just one from a recent case at my institution. This patient had a scalp squamous cell carcinoma that was provided in the history and the clinical information, and had a rounded appearing mass in the parotid gland. The report stated the mass appears benign. Differential diagnosis would include parotid primary neoplasia, benign mixed tumor, or sialocele. And that's just wrong on every level and largely inappropriate given the information that was provided. Follow-up recommendations are, again, a new error that is very commonly seen, leads to a significant amount of medical legal problems. Follow-up recommendations are recommended as the radiologist's responsibility by the ACR. So within those guidelines, how we think we should provide some temporal resolution for what we see on an imaging study, that's in our court. If you think follow-up examination is necessary at whatever time or by another modality, strongly and definitively put that in the report. No ambiguous language, not if of clinical concern, follow-up examination may be performed. No. If I think the lesion is significant and I want to see what it does over time, that's stated in my report clearly and succinctly. The time interval that you suggest, that's a little bit artsy, but certainly it would vary by the potential for the disease to progress. Things that you think may be malignant and or aggressive, shorter interval follow-up. Things that you think can be comfortable with a little tincture of time for evaluation, 6 months or a year. Again, that's our responsibility. That should be in your report. Disclaimers are one of those things that we see on our resident and fellow reports, and I hope that most of us have moved away from many of them, but let's just talk about them for a moment. In a court of law, radiologists is required to note the study was unable to answer the clinical query. So no disclaimer will protect you from potential medical legal liability. There are hundreds of examples here. Just a few things that you might consider. How about a CT to evaluate a tongue lesion in a patient who's got literally a mouthful of dental amalgam? You can't adequately depict that lesion despite your best intents. That exam is unable to answer the clinical query of what that disease is and how big or how invasive it may be. There are many other examples, however. I'm sure you've had the referral for stone disease on an MR examination. That's a tough pickup. How about MRs for conductive hearing loss? I'm sure you've all had many, but remember that disclaimer. Can't do it, not protective. If you think another study is the appropriate examination, stipulate that. It's certainly better if we catch this before the exam is protocoled and performed, but when you're faced with reading an inappropriate study, we've got to guide people in what is the appropriate exam. Arguably everyone's favorite quote about this whole topic, the first thing we do, let's kill all the lawyers, and that's from Shakespeare. And we know he didn't think very highly of lawyers based on that quote alone. A few medical legal sticky points. Misdiagnosis of prior comparison studies, and that's an important topic. Consultations and sources, the idea of tailoring a report to the referrer, think about addenda, and then incomplete or non-diagnostic studies. So I went for this misdiagnosis to, I think, the person who we all know as the ultimate source of information about misdiagnoses, Dr. Larry Ginsberg at MD Anderson. And he literally poured through exams to find me exactly the right one. And I think this is a really nice example. So in 2015, this patient is in the midst of a multiple surveillance series for thyroid carcinoma. And the PET and the CT examinations are being performed to evaluate for metastatic thyroid carcinoma. And you're clued into this now, and you're looking at that tongue base, and you're saying it's hypermetabolic, and it's something there on the CT as well. But we're surveilling for thyroid carcinoma. Put yourself in the moment. And that wasn't commented on. So that's 2015. The patient has other examinations, but culminating in this examination in 2017, at which time the patient now has level 2 lymphadenopathy and a much more conspicuous tongue base cancer. This was indeed squamous cell carcinoma. This patient had tumors and a neck dissection and has done well. How do you interpret the exam from 2017, now having the retrospective data of multiple misses of this study? The common vernacular for this is, I got thrown under the bus. And what we want to avoid is throwing our colleague under the bus. And I love the little sticker on the left, 0 days since an employee has been thrown under the bus. We'd like to get our numbers up a little higher than that. Word of advice, keep calm. Don't do it. Misdiagnoses. This has been well described in the literature, and I would call your attention to just about anything written by Dr. Leonard Berlin over the last 15 to 20 years. Dr. Berlin has written exhaustively about this topic, as well as all medical legal concerns. But the misdiagnosis, the way to think about this is 4% of radiologic interpretations in practice contain errors. We will find errors, as in that case that we just showed. When discovered, work to correct the error with promptness. Inform the interpreting radiologist. They should generate an addendum. That addendum should be communicated to the referring physician. If they cannot be informed in a timely fashion, you dictate that study that you're reading, noting the abnormality, but without making specific reference to the abnormality on the prior studies, unless doing so is absolutely crucial. I think it's important to use RADPEER or another reporting format for errors, and if your institution is so equipped, notifying risk management is a very good thing to do. Style is important here to avoid throwing your colleague under the bus. And how you word that report, there are many ways you can approach it. The lesion is more conspicuous on the current study, or it was previously subtle, but avoid just saying simple things like, it was missed on the prior examination. Consultations are another potential source of medical legal errors, and just a few points again from a lot of published data. When you consult with another colleague, it's best to mention them in your report, and that doesn't provide medical legal exposure to them. It just says that, I was confused or concerned or needed some more information and would like to have had a consultation on this and obtained it from this person. It's not going to keep you from being sued if that comes to fruition, but it does provide backup data that you were concerned about an item. Quotes from any references or materials, articles that you utilize in generating the report should be in the report, and a reference in a report is an appropriate item. The whole entity of curbside consultation is very problematic. Many of us are asked to do that routinely, and I hope that you've all come up with a way to deal with this at your institution that is appropriate. Obviously, those images are best submitted for additional review, so we get a paper trail and everything is kind of like on the up and up. But curbside consultations occur. We can't avoid them. Remember that very often you're viewing this in a suboptimal fashion. You're provided with little information or maybe only a minimally appropriate degree of information. Looking at somebody else's study, everything is suboptimal there. Both your memory, their memory, particularly in like documenting your involvement on their subsequent office notes, can be flawed, and you can get into trouble quickly. Your role very often is inflated, or your statements may be misconstrued. So curbside consultations are very problematic, and if you can avoid them, that's certainly the best way to deal with this. People have talked about tailoring reports to appropriate referrers, and I will tell you my personal opinion about this, and that is I generate one kind of report, and I generate the same report all the time. Consistency, consistency, consistency. The problem, I think, when you're thinking about the appropriate referrer to tailor the report to is, who do you tailor it to? Because the patient's going to be reading the report as well. The patient may be referred to a more subspecialty physician for care, and that can be problematic. So I generate a single report, and I try to make my impression very concise and easy to deal with. Phone communication, again, can be key. Additional communication performed outside that radiology report can be the thing that is the most important overall. When asked to provide addenda, don't think for a moment that you can alter time. You don't suddenly become Doctor Who and can dial it back to before anything was said earlier. Timestamps are there, and they're there for a reason. So significant addenda, they are important. They can save you, but they're handled as an urgent communication, and remember the timestamp is always going to be there. Significant addenda, in my humble opinion, should always be handled with a call to the referring clinician that you are generating that addendum. Non-diagnostic studies are another potential pitfall medical legally. If you feel that an examination is non-diagnostic quality, don't bill a professional fee. Billing the professional fee is essentially saying, I'm responsible for this data now, and I'm going to generate a report. No professional fee. Reporting to a minimum, if any reporting at all. Communicate with the referrer. Have an appropriate examination performed, or schedule the patient as soon as possible. Expedite that follow-up examination that is the appropriate and hopefully diagnostic exam. My last quote here from Kafka. I think that's probably an appropriate way to end. A lawyer is a person who writes a 10,000-word document and calls it a brief. So, I'm done. In conclusion, I think that head and neck imaging and reporting has a few areas that are relatively unique in terms of medical legal exposure. This entity known as the screening sinus or diagnostic sinus CT examination. A lot of head and neck cancer, both seen and unseen, and primary staging of neoplasia. Another item I think it's important for us to consider in the medical legal purview of all this is there's really a paucity of people who are head and neck specialty radiologists, and what we do, our interests and our expertise are a little bit unique here. Remember all those general considerations of medical legal exposure as well. Adequate communication, urgent communication, the occasional misses and how we should deal with those. Remember that at the end of the day, you're working for the patient, but you're also working for the referring physician, and you're working with and for your colleagues. Treat each one with equal respect, and you will avoid, or at least limit, your medical legal exposure. Thank you very much for your kind attention. I certainly appreciate it.